Hi, and welcome back to Student Nurses Success. Today we're going to cover coronary artery disease. Coronary artery disease will lead to the development of myocardial infarction or acute coronary syndrome. So it's an important topic for us to cover. When we're talking about coronary artery disease, we're really talking about insufficient delivery of oxygen to the myocardium or the heart muscle itself. Coronary artery disease is basically clogged up arteries from plaque and cholesterol, or if a thrombosis or a clot forms in the coronary artery, what happens is there's decreased blood flow to the myocardium. This decreased blood flow to the myocardium can result in death. So part of the heart muscle can actually die if it doesn't get enough blood flow. Now there's two things, there's ischemia and there's infarction. Ischemia is reversible. Ischemia is lack of blood flow. That lack of blood flow does cause pain. We often talk about that as chest pain or angina. However, if that lack of blood flow goes on long enough and there is no blood flow, the heart muscle can start to die. In those particular cases, we call that an infarction. Once we've moved into the level of infarction, that means that the heart muscle has actually died. It will not come back, and that part of the heart is then dead. So we look at this picture here. This is a picture of the heart and the coronary arteries. The coronary arteries feed the heart muscle. So it's important for them to not be blocked because the heart muscle demands a lot of oxygen in order to pump. The coronary arteries actually feed off of the aorta, and they feed off the aorta because your heart needs lots of oxygen and lots of blood flow. And so they take the blood pretty much right at the source, right where the left ventricle pumps it out to the aorta, and these coronary arteries feed off of there. Now you have the right coronary artery and the left coronary artery. The right coronary artery feeds the right ventricle. The left coronary artery is much larger. It feeds the left ventricle, which is stronger and a bigger part of the heart. And also, the left coronary artery has a lot more branches to it. So now let's talk about ischemia or a lack of blood flow. Ischemia to the heart muscle, actually, there's four main causes. One can be plaque formation, and plaque formation is when plaques actually develop and build, and cholesterol builds up in the coronary arteries. And actually, quite frankly, plaque can build up in any of your arteries and in any of your vessels throughout the body. But in this particular case, we're very concerned when it builds up inside those coronary arteries because it's going to decrease blood flow to an area of the heart muscle. Let's talk about plaque formation. Plaque is formed for and when lipids actually collect inside the vessel wall and start to oxidize. This oxidation means that they get larger and larger and harder and harder. And so these plaques do not move. So if you have a vessel here and you have a plaque that develops, it gets larger and larger and harder and harder. And as it oxidizes, monocytes start to collect and cause inflammation, which then makes it grow even bigger. And so this thing just keeps getting bigger and bigger and bigger. And as it gets larger and larger, you get less and less blood flowing through the vessel. At some point, it can grow large enough that actually a full blockage can occur. What also may happen is that this plaque may actually start to separate and rip off and actually block the vessel from it being dislodged. And in this particular case, when it starts to dislodge, we get platelets that aggregate there and we actually develop a whole clot there. So as that plaque gets larger and continues to grow, it actually may rupture, pull away from the cell wall, and actually cause a thrombosis or a clot. So that's where we up here get this plaque formation and or thrombosis from a plaque that ruptures. Another cause of ischemia or decreased blood flow through the coronary arteries is endothelial cell wall impairment. Inside your vessel walls, you've got little endothelial cells, and these little endothelial cells can get damaged. What damages them is smoking, high blood pressure, diabetes or high glucose content in your bloodstream, stress, and even inflammation. As these cells get damaged, they can also leak and bleed. And when they leak and bleed, platelets aggregate there and actually can start to form a clot. And obviously, if you have a clot, you're going to have decreased blood flow through there. The third thing is just decreased blood flow in general through the coronary arteries. Now, that can be from, we've already talked about it, could be from plaque or it can be from endothelial cell wall impairment. But what I'm talking about here is actually decreased volume. If you are dehydrated, have decreased blood volume, or decreased blood pressure, you cannot get enough blood through those coronary arteries in order to perfuse that heart muscle. And so in this particular case, I'm talking about decreased circulation through the coronary arteries causing ischemia. The last cause of ischemia is something called vasospasm. In some individuals, their coronary arteries will just spasm and they actually constrict, like vasoconstrict, and can decrease blood flow through them. That's kind of a whole separate issue. It can cause ischemia. It does cause chest pain, but we do manage that by giving vasodilators. It's a little bit different process. So let's go over here and talk about these plaques a little bit more. So these plaques that develop can actually block the arteries, leading to decreased blood flow, ischemia, or if they get completely blocked for a long enough period of time, it's actually going to cause necrosis known as infarction. Remember, when we don't have enough blood supply, the area will start to die and necrose. In this picture down here, you can actually see necrosed areas on this heart. So this coronary artery got blocked, blood flow didn't come to this section of the heart, and this necrosed and died. Now, we know that ischemia or lack of blood supply to an area will cause pain. In our heart, we call that pain angina. Angina is chest pain from lack of blood flow through the coronary arteries. Now, we can have stable plaques and unstable plaques. A stable plaque is nice and fixed and in place. So if we have a plaque here, we got a stable plaque. It's not really, it's growing probably slowly, but it's not a big ordeal, and blood is still going through it. What happens with stable plaques, they lead to what we call stable angina. With stable angina, you have chest pain, but that chest pain is relieved with rest. So, what causes chest pain is when you have increased demand or increased activity, you need increased blood flow through that artery to get to the heart muscle to increase its rate and to increase cardiac output to support that activity. In a stable plaque, when you demand more, when you start exercising, if you have a stable plaque, you're probably not going to get enough blood flow to your heart muscle, and your heart muscle is going to get a little ischemic, and it's going to start to hurt, and you're going to have angina, and that pain's going to make you stop that activity. And when you stop that activity, then that extra demand has backed off, and now the flow that you have is probably enough, and that chest pain is going to go away. So we have different types of angina. Again, the first one is stable angina, which is from a stable plaque, which is chest pain relieved when we rest. So when we take that extra demand off our heart muscle by reducing physical activity, then that chest pain goes away. So the flow is enough for everyday stuff, but not for extreme physical activity. And keep this in mind, when you increase myocardial oxygen demand, as is the case with physical activity or exertion, angina will develop if the heart's not getting enough blood flow or oxygen. Now we have something called an unstable plaque, and an unstable plaque causes unstable angina. An unstable plaque is a plaque that is at risk for ripping off and flopping around. So if we have this plaque here, if it becomes unstable, that means it can actually rip off from the edge and actually start to block the whole artery. So as we increase our myocardial oxygen demand, we have a full blocked artery. And so we're getting ischemia, but because that artery is pretty well blocked, it's not relieving or it's not going away when we rest because there's still no blood flow. The problem with unstable plaques and unstable angina is it's pain not relieved. We know the blockage is still there, and it can lead to infarction or dead tissue because there's no blood flow distal. So, unstable angina is pain not relieved with rest, and this is dangerous. The last type of angina is something called Prince-Metal angina. This is angina from the coronary artery spasm that we talked about. When the artery spasms and constricts, it's going to decrease blood flow and it's going to cause ischemia and chest pain. Patients usually manage that by taking nitroglycerin or some type of vasodilator. It's not really related to plaques at all. Let's talk about our cardiovascular risk factors. Who's at risk for having a myocardial infarction and coronary artery disease? Well, age, as we get older, that does increase our risk factors. Our arteries get narrower, they get more plaque buildup in them as we get older. Family history, we know some individuals have more cholesterol level and family history of heart disease, and male versus female. So males always have an increased cardiovascular risk. Females actually have a decreased cardiovascular risk until menopause. And at menopause, their risk factors equal that of males. So estrogen is protective for a while. The other risk factor is your lipid and cholesterol level. Now, cholesterol's good. I mean, cholesterol's helpful. It repairs tissues in our body. However, too much cholesterol is not good. Cholesterol should be less than 200 would be ideal for your cholesterol level. Now we have good cholesterol and we have bad cholesterol. Good cholesterol is lighter. It's fluffier, and as it circulates through the bloodstream, it returns to the liver. We want our HDL or our good cholesterols to be greater than 60 on our lab values. Now, LDL is our bad cholesterol. It's thick, heavy, and sticky, and it sticks to the inside of our vessel walls. That's what really increases plaque development. We do not want a high LDL level. We want LDL less than 100 or less than 130. Now, triglycerides are a different type of cholesterol. They are for energy and storage of fat. They are helpful. However, too much is not good, and we want our triglycerol levels to be less than 150. Other risk factors include hypertension, diabetes, and something called metabolic syndrome. Metabolic syndrome is a collection of events. It's a collection of increased blood pressure, increased blood sugar, increased waist circumference, and also increased cholesterol levels. We know that that combination increases our cardiovascular risk factors. We know that high blood pressure and diabetes, if we go back up here, causes endothelial cell wall damage, and that is why it is a risk factor. Nutrition, a diet high in fat, increases our risk factor, and obesity does as well because it increases our cholesterol. We also know that chronic inflammatory conditions also increase risk of cardiovascular disease. So now let's go down and let's talk about acute coronary syndrome. Acute coronary syndrome includes three things: unstable angina, something called a non-STEMI, which is a partial thickness damage to the heart muscle, or a STEMI, which is a full thickness damage to the heart muscle. Now, keep in mind, remember I told you your left coronary artery is more commonly blocked because it's larger, has more branches. And so, just by chance, you're going to more often see a left coronary artery infarction or blockage. Unfortunately, that's the problem because the left ventricle is the main pumping chamber. So when we have left coronary artery infarcts, we're going to actually see more development of heart failure over time because that left ventricle is your main pumping chamber and it needs to be the strongest part of your heart. And if that left ventricle dies or parts of it die and get damaged, that's going to end up causing heart failure down the road. In general, manifestations of acute coronary syndrome include angina, chest pain, and that chest pain can radiate down the jaw, the neck, or the arm, shortness of breath, fatigue, and that fatigue is from decreased cardiac output. Now, remember, if you have acute coronary syndrome, you have ischemia to your heart muscle. And what's happening with ischemia is that your heart muscle can't pump well because it's not getting enough oxygen. And that ischemia can actually lead to infarction or death of a piece of your heart muscle. And if part of your heart muscle isn't contracting, that's going to decrease your cardiac output. You can also develop diaphoresis, nausea, indigestion. We often see tachycardia or increased heart rate because the compensation for decreased cardiac output is to increase your heart rate. When we have decreased cardiac output, we have decreased perfusion to our kidneys, and with that, we have decreased urine output. And our lack or decrease in cardiac output also leads to weak peripheral pulses. Let's talk about the three types of acute coronary syndrome. The first is unstable angina. Now, unstable angina is usually from an unstable plaque. So, this plaque is blocking an artery, and this unstable angina is causing chest pain that is not relieved with rest. So, we do need to seek care. The good thing about unstable angina is that there is no damage to the heart yet. It's still in ischemia and not in infarction yet. So the heart has not died, no piece of it has died, and there is no permanent damage. However, this chest pain is not going away, which indicates that part of your heart muscle is not getting enough blood flow. How we know that a patient has unstable angina and not an infarct or a heart attack is because we will not see biomarkers. Biomarkers are the lab values or the lab tests that I have right here. When heart muscle dies, it releases cardiac enzymes. And these two cardiac enzymes are troponins and CKMB. So as your heart muscle dies, so in this picture here, you see these little pieces of dead heart muscle. As these die, they release these cardiac enzymes, and these will start to rise and increase. So if a patient presents with unstable angina, they're having chest pain, we check their lab values and we see that there's no increase in their cardiac enzymes or their troponin levels. And in that case, we're saying, okay, you have ischemia to your heart muscle. We need to manage this. However, we're lucky because right now there's nothing, no piece of that heart muscle has died yet. Another lab value would be sedimentation rate, which would just be indicative of inflammation. So with unstable angina, you have no biomarkers, no increase in these lab values, and the EKG looks normal. But you have chest pain not relieved with rest. Now, the next step is something called a STEMI. A STEMI is a non-ST elevated MI, non-ST elevated myocardial infarction. Now, this is infarction, so there is heart muscle damage. So we do have this is a heart attack. So we do have positive heart muscle damage. In a non-STEMI, you have chest pain not relieved with rest. Okay, because your ischemia, you have lack of blood flow to an area and a part of the muscle has now started to die. But because it's a non-STEMI, it's a partial blockage and a partial damage to the myocardial wall. So the whole thickness of the wall isn't dead yet, just part of it is damaged. You know that it's a non-STEMI because you have your chest pain not relieved with rest and you have biomarkers. So because there's damage, we start to see this increase in troponins and CKMB and sedimentation rate. However, when we look at the EKG, there is something called the ST segment. That ST segment is not elevated in a non-STEMI. It's a non-ST elevated MI. So the EKG still looks normal. So in unstable angina, you have the chest pain. In non-STEMI, you have the chest pain plus the biomarkers. And then our third one is the STEMI. The STEMI is the worst, okay? With a STEMI, you have chest pain not relieved with rest, but it's a complete blockage and a full thickness damage through the myocardial wall. So the whole wall is dead and damaged, and that's a much worse problem than a non-STEMI. With a STEMI, you will have positive biomarkers because you do have damage. In addition, on your EKG, you will see the ST segment elevated, and that indicates there's ongoing myocardial ischemia. So for a STEMI, you have the chest pain not relieved with rest, the biomarkers, and the ST elevation. So the STEMI is the worst. But all three of these fall under the category of acute coronary syndrome because they all need to be emergently managed. Because an unstable angina can turn into a non-STEMI or a STEMI at any time. So, what are our complications of acute coronary syndrome? Well, heart failure is your big one. If a piece of your heart muscle dies, then the heart can't pump as efficiently as it was. So, a lot of times patients who are post MI can develop heart failure. Now, there's a degree. Sometimes the heart failure is very severe, and sometimes it's just a tiny piece of the heart, and things aren't as bad as they could be. We also know that ischemic heart disease develops after myocardial infarction because that heart muscle is damaged. So over time, we start to see a decrease in cardiac output and pump failure in the heart. The other thing that can develop is arrhythmias. Because a piece of the heart muscle is damaged and electrical activity moves through the heart muscle, sometimes that electrical activity can get distorted. You can develop something called a bundle branch block or a heart block or even VTAC, which is ventricular tachycardia. And this would be a lethal arrhythmias. Bundle branch and heart blocks. Aren't as well, bundle branch wouldn't be lethal. Heart blocks can range from not a big problem to a big problem. And then the other complication of acute coronary syndrome is pericarditis or inflammation of the heart post damage. And there you go. Pretty complicated, but I think you can kind of sift through the information here. Make sure you watch our other videos on other cardiac disorders because we've only covered one here and there's other things that can go wrong in the cardiac system.